Hello, and a very good afternoon to all the wonderful people who have joined today. On behalf of our organization, Dentist Channel Online, this is your host, Dr. Ifrah Shakeel, warmly welcoming you all to today's webinar. Well, I would like to extend a warm welcome to Dr. K.S. Pandaw for coming on board with us. Thank you for joining as a guest speaker for today's webinar, Doctor.
Thank you so much, ma'am.
Well, today's topic is fundamentals of dental implants, evolution, types, and techniques. So, Dr. Pandaw will provide insights about the basics of dental implants, including the evolution and types of implants, the design and surface modifications, placement techniques, tilted implants for full mouth rehabilitation, pros and cons. So, stay tuned with us to know more about implants. And also, I'll be giving like a brief intro about the Quickdent implants. It is a home to the most cutting edge dental implant systems, which are of premium quality with high osseointegrative property and innovative design. Their vision is to create a sustainable range of dental implants catering to varied jaw conditions. The USP of Quickdent is that they are graftless, and one of the prime features of the implant system is that they are immediate loading with available two-piece and one-piece regular and basal implants. So, the Quickden implants follow the basic principle of ABC, translating to all on basal cortical immediate or delayed loading concept. So, without wasting further time, I would like to start by giving a brief introduction about Dr. Pandaw. He has completed his BDS from GTC Raipur in 2008, and he has completed his MDS in periodontics. And since 17 years, he is practicing in Central India as a dental surgeon and a visiting dental implantologist. He has done extensive training of dental implantology with CSM Implants South Korea and with Veritas Biovention. Dr. Pandaw has done extensive training in immediate function loading from International Implant Foundation, Germany, and he has been awarded the fellowship of International Academy of Oral Implantology. Dr. Pandaw is a key opinion leader of Quickden Dental Implants, and he was a key opinion leader of CSM Implants South Korea. He has given many lectures and presentations in various national and international conferences. He's a professional dental photographer and he's the director of Institute of Dental Excellence Raipur since 9 years. Till present, more than 500 dentists have got training on dental implantology from his institute. So once again, I, and on behalf of our entire team, welcome you to today's webinar, Doctor. And for all the participants, I may inform you that if you have any doubts or queries during the webinar, kindly put your questions in the Q&A box so that we address at the end of the session. So over to you, Doctor.
Thank you so much, ma'am. So, shall I start?
Yes, Doctor.
Yeah. So, very good afternoon, everyone. First of all, I would like to extend my sincere gratitude to Dentistry channel for organizing this webinar. Such a platform like this plays very crucial role for betterment and advancement of the dentistry because they bring together all the professional where we can share our knowledge and experience. So, thank you so much, ma'am, and thank you all of you for joining me for this webinar. So, let's start today's webinar. Let me share. Is it visible, ma'am, screen?
No, not yet, Doctor.
Okay.
Yeah, now it's visible.
Okay. So let's start today's webinar. So I am Dr. K.S. Pandaw. I am a conventional and corticobasal implantologist. And today we are diving into the topic fundamentals of dental implant, a comprehensive overview. In this session, we will see the evolution of implants, how this dental implantology evolved from the ancient era to the 21st century. And then we will see the types of implants, the techniques, about the conventional implants, bi-cortical implants, what is the delayed loading, immediate loading. So these all things we are going to cover. Okay, so let's start today's topic. So we will start from the very basic. If we talk about the health, health is not only physical health. WHO consists physical health and the mental health both together. So if we say what is the two basic need of human to be a healthy, so it is a good food and look good, right? Good food for better physical health and look good for the better mental health. Okay, and our tooth is playing very important role for all of this, because if you don't have a teeth you can't taste your food, and without teeth you can look like this. Okay, so tooth can enhance your aesthetic value also, so it is very important for the uh, overall health. So since many years we are searching for option for replacing the missing teeth. So these are options we know, that removal prosthesis, crown and bridge, and dental implants. Yes, and we all know that the best option to replace missing teeth is dental implants. Okay, so we'll start from the very basics. So let's understand what is implant. Implant is any object or material which is placed or grafted into the body for any particular reason, like for the therapeutic reason, for diagnostic, prosthetic, or experimental purpose. So it is called as implant. And what is dental implant? The implant which serves for the purpose of teeth is called as dental implant. It means any alloplastic material or device that is surgically placed into the oral orofacial tissues and used for the encouraged functional, therapeutics, and aesthetic purpose is called as a dental implants. Okay, so let's come to the first part of the our webinar. So first is the evolution of dental implants. You will be very surprised that China in 2000 BC, uh, bamboo pegs were used as a dental implants. Then many uh, things are tried, like 1000 BC Egyptian used gold wire to stabilize the teeth. Shells in the Mayans peoples use the seashells, stones, or animal bone as a dental implants. Uh, if we can, if we try to divide the whole evolution, we can divide it into a titanium era, and the 21st century, the digital era. So let's talk about the pre-titanium era. It is 1900 to 1950. In this period, before uh, the in this era, mainly the we are we try to many metals like iridoplatinum, vitalium, and and other metals uh, for the dental implants. Like in 1913, Dr. E.J. Greenfield developed a hollow cylindrical implants which is made up of iridoplatinum, but they become failed because they are not authenticated to the body. So major revolution comes at 1950, which is called as the birth of titanium implants. And this man is uh, having all the credit uh, for the search of the osseointegration. In 1952, Dr. Brainmark, a Swedish orthopedic surgeon, discovered the osseointegration by his experiment when he placed a titanium rod into the tibia of the rabbit, and after a few months, when he tried to remove it, he was unable, and he called this phenomena osseointegration. And in 1965, Brainmark placed the first successful titanium dental implants in a human patient, but it took very long year to commercialize it. In 1980 to the 2000, in 1982, the Toronto Conference officially recognized the osseointegration, with marking the global acceptance of the Brainmark. Then the work on a titanium will begin. 1986, the Nobel Pharma, which is known as nowadays known as the Nobel Biocare, commercialized the first also integrated implant system. Then we worked over the how to modify the surface, how to modify the design for getting the better also integration. Now we are in the 21st century, which is known as the digital and immediate loading era. In this era, we work on the surface characteristic, the design of implant. Like in 2000, the Strawman first introduced the SLA technique. SLA means sand blasted acid test techniques. Uh, uh, Earlier, the implant was only a machine surface polish implant, but to increase the bone to implant contact, we try to roughen the surface by sand blasting, and through the sand blasting, the surface become rough, macro roughness, and for the macro roughness, the acid is. So this technique is called as the SLA technique, sand blasted and acid is technique. Then brain mass techniques were the delayed loading. Then many works are we did for the immediate loading techniques, which allowed patient to receive teeth within few days instead of month. Now the material is changing from titanium. We are going to shift into the zirconium implant, and we are try to search more biocompatible material uh, in place of titanium. Titanium is still a gold standard metal which is used for the osseointegration for dental implants, but the modulus of elasticity is very different from if we compare the bone and the titanium. So we are searching more options like zirconia and other materials. And now in 2010 to 2020, a digital implantology and guided surgery era, in which through the CBCT we can plan our surgeries, and we can plan a surgical stand, and we can do the computer guided implant surgery. And nowadays it has become very popular, and now we have a all-in-4 all-in-6 concept, tilted implant concept, to which allow the full arch rehabilitation with minimal implants and in a minimum time. So this is how our implant evolved from the ancient era to the 21st centuries. Now, let me give you a basic idea about the types of dental implants. If we classify the dental implant, we can classify the dental implants on the basis of implant design, on the basis of mechanism of attachment, the design of the implants, the surface characteristics of the implant, and the material use. So we will see one by one. First is the implant design. Uh, Implant design, according to implant design, it can be endosteal, subperiosteal, transosteal, intramucosal. Okay, now we will see one by one each of these. So endosteal implant. Endosteal means inside the bone. So this implant actually rests inside the bone. It is surrounded by, it is rest in a cancellous bone. So this can be made of metallic, ceramic, polymeric material, and available as a blade or screw as center. Nowadays, most of the implants we use are the endosteal implants. It is the most commonly used and safer method. Second is a subperiosteal implant. Subperiosteal implant, it is used in a atrophic jaw. It rests on the rest over the bone. When there's a bone volume is very less, then this implant can be subperiosteal implant. They are the light-weighted metal implants. It is placed under the gum line on the top of the bone. Third is a transosseous implant. Transosseous implant, trans mean through and through. So it is recommended for the patient with insufficient jawbone. So these implants are the post passes through the jawbone. Usually the intermental bone we use. And it is placed through the chin bone into the mouth. And last is the intramucous implant. We are not using these type of implants initially. They are developed. They are actually a mushroom shape with a titanium projections. It is inserted into the mucosa, and it is used for the denture stabilizations. According to on the basis of the mechanism of attachment, initially the implants we uh, uh, the implants has a fibro integration concept. Then after the search of the osseointegration, now we are using osseointegration concept for the implants. This fibro integration, it means the titanium in this fiber integration, the titanium is not fused with the bone. It is surrounded by the soft tissue, the connective tissue, which is not able to provide sufficient support or to stabilize our prosthesis. So there's an encapsulation of the implant with the soft tissues. This and abutments are attached immediately after the implant placement. Now what we are using, the implant system is based on this technique, which is known as the osseointegration. Osseointegration means, if you see in the light microscope, the implant and bone looks like it is fused together, so it is called as the osseointegration. But if you see in the electron microscope, there's a peri-implant laminas present there. So it is not a fused with the titanium. Bone is not fused with the titanium. Actually, it is a closely adopted to the implant surface. So the implant is placed in a direct contact with the bone. If we classify dental implants according to the design of the implants, we can classify it into cylindrical implant. The first image you can see is a cylindrical implant. They are a smooth surface implant. They don't have a thread. They are push type of implant. Then second is a thread implant, which we are using nowadays. Threaded implant mean it is a screw shaped implant which has the aggressive thread over the surface. And third is a plate to leg implant, where the threads are like broad plates. And next is the perforated implant. If you see the picture of a right side, the smooth surface implant has a perforation. So the systemic perforation is uh, present in this implant for the better osseointegration. And last is a solid implant, which is a one piece implant, and hollow implant. If we classified implant according to surface, uh, initially the implant which we used are the smooth surface implant. They don't have any surface characteristic or any thread or any design over the implant surface. These are the smooth surface implant. We had to do osteotomy, and we need just to tap the implants in the osteotomy site. And to increase the bone to implant contact area, we modified this smooth surface to the machine surface. So what is a machine surface? It has a screw thread over the implant surface. So by this way, we can increase the bone to implant contact area. So these are machine surface. But still, if you see this photo, it is a smooth surface implant. So it is a machine surface implants. Now, next is a texture surface implant. After making this screw machine surface implant, we want more bone to implant contact area. So we roughen it with the various method like sandblast. So this surface become textured, then come to a texture surface implant. Then to make the surface more active, which can enhance the osseointegration, we can coat the implant surface by the hydroxy apatite crystal, or many things are there. So these implants are called as the coated surface implants. Okay. And last, according to the material used, metallic implants, ceramic implants, polymer implants. So most of us, what we are using is a metallic implants. Titanium is used for the implants. So we saw that there's a various type of implants: endosteal, subterrestrial, but majorly when we are practicing, we use only majorly two type of implants. One is a conventional implants, which is a rough surface two-piece implants, and second is a bicortical or basal implants. So most of the dentists use conventional implants, some of the dentists use bicortical implants. So conventional, if we see the conventional implant treatment, these implants are endosseous implants. It rests in the cancellous bone. Okay, so it works on the principle of osseointegration. This conventional implant works on the principle of osseointegration, and it is a two-piece implant with a rough surface. It can be active implants and it can be passive implant. So conventional implant can be again classified into two types: active implant and passive implant. So what is an active implant? Active implants are when we modify the design of the implant, or we do any modification in the surface technology, which increase the which enhance the osseointegration rate, is called as the active implant. So if we make the threads more aggressive, it will become more active. If we coat the surface with hydroxyapatite like material which fastens the osseointegration, it is called the active implant. And second is a passive implant. Passive implant has less aggressive thread. As it is a two-place implant, uh, these are the components. First is a fixture, which is called as implant. Then there's a superstructure, which is screwed over the implant, which is called as the abutment, and our crown is cemented over the abutment. So this conventional implants comes in two parts, and it is used for mainly used for the delayed loading. Second, the most commonly used implant is the bicortical implant or base implant. It is called as a bicortical because it engages the both of the corticals. It is mainly based on the also fixation. The conventional plants based on the concept of also integration, but here the bicortical implants is based on a also fixation. So it is used for the immediate functional loading. They are the one piece implant and smooth surface implant. So it is called as a bicortical because uh, it engages the both of the cortical. First cortical, the uh, uh, the alveolar ridge is called as the first cortical. Second cortical is the in mandible mylohyoid is the intermental bone, or you can say the nasal septum. These are second cortical. So this bicortical implants engages the both first cortical and second cortical. So therefore, we can use this implant for the immediate function loading, and they are the one-piece implants. If you see the type of cortico-basal implant, it can be smooth surface or it can be a QS-like design, which is known as a compressive implant. All the bicortical implants are single-piece implants. So if they are single-piece implant, it means we have to cement our processing. So these are the basic difference between the conventional implant and bicortical implant. Conventional implants are the rough surface, two-part, two-piece implant where we can give the screw-retained processes. But here, the cortico-based implants, they are the smooth surface implant, they are one-piece implant, so we can give only a cemented processes. And they are using for, we can use this cortico-basal implant for immediate function loading, and for conventional implant, we can mostly use it for the delayed loading implants. So it is a basic difference between the conventional and the bicortical implants. On the basis of technique of implant placement, it can again divide into the immediate, early, and delayed. So according to time of placement, it can be immediate placement, early placement, or delayed placement. According to the time of loading, it can be called as the immediate loading, early loading, and delayed loading. So don't get confused when someone is saying that that we are doing immediate implants. Immediate implants mean we are extracting the tooth and immediately we are placing the implant. It's called is the immediate implant placement. And early placement mean after 1 to 2 months, when there is a soft tissue complete healing and bone healing is not completed, and then we place the implant. It's called as early implant placement. And delayed implant placement mean after soft tissue healing, complete soft tissue healing, after complete bone healing, when we place the implant, it's called as a uh, delayed implant, which is a conventional technique, which is given by the brain mark. So when we talk about the immediate placement, so it is depend on the time of the placement of the implant. Okay. And loading, time of the loading is a different thing. If we say that immediate loading implant means immediately after placing the implant, we can load it with the processes, either a function or the non-function. We load the processes. It's called as the immediate loading implants. And early loading implant, before complete osseointegration, we are putting some load to the implants. It's called as the early loading implant, or we can use it in a progressive loading implant. And delayed loading means it's a conventional technique where Ben says that after implant placement, we have to wait for 3 to 4 months for the mandible for complete osseointegration, and for 5 to 6 months for the maxilla for complete osseointegration. And after complete osseointegration, when we load it with the prosthesis, it is called as a delayed loading implants. In corticobasal implants, we do the immediate function loading implant. Immediate function loading means we are immediately placing the implants, immediately load it, and you can use it functionally. So it is called as an immediate functional loading. In conventional plant, sometimes we also do the immediate loading, but most of the time it will be a non-function loading. And we had to choose this. We had to use non-functional loading. We had to use functional loading. Okay. So immediate implant placement depend on the time of the placement. Immediate loading is concerned with the loading of the implants. So if we say the what is a delayed or early or immediate, if we put it after the 3 month complete osseous integration, so it is called as a delayed. When we place the implant after the extraction of 1 week or 2 3, it is called early, and immediate when within 42. But there's a no particular uh, consensus. So in 2013, in fifth ITEC consensus, they uh, they specify it that immediate loading means when we are loading the implant within a 1 week. Immediate loading doesn't mean we are loading it immediately in 24 or 72 hours. If it is loaded, the implant is we are loading implant within a 1 week, it is comes into the category of immediate loading. And if we load the implant after 1 week and before the 2 month, before the complete osseous we are loading it, this comes under the category of early loading. And conventional loading, what we are doing uh, after the complete osseous integration, when we load the implant, is called as the conventional loading implants. Okay. So delayed load, let's see about the delayed loading protocols. Delayed loading protocols given by the Brainmark in 1983. In delayed loading implant, we submerge the implant 1 to 1.5 mm below the bone margin to avoid the micro motion above the 100 micron, because when movement is above the 100 micron, it uh, the osseous integration, it become a fibrosis integration. So for that we had to submerge the implant, and it is the most predictable way, most research way, and most evidence based, the conventional loading delayed loading implants. So we are placing the implant, we will wait for 3 to 6 months for the mandible and 4 to 6 months for the maxilla. So these are the standard protocols going on, where we do the extraction, then we will wait for 3 to 6 months, then we do the first stage surgery where we place the implant, then after 4 to 6 months we will do the second stage surgery where we place the gingival farmer, then after 1 week we took the impression and the process to the patient. So if we see after the action, almost half and 1 year is taking for the extended protocol of the brain mark. So these are the disadvantages of this delayed loading implant. This delayed loading implant based on the bone response, and it is time consuming. Many companies are using, so these are less economical, and we don't have a time to conserve our soft tissue aesthetics. So these are the disadvantages of the delayed loading implants. So now in new era uh, we are shifting to the immediate loading. To overcome this issue, in 1976, Schultz and the Hemek introduced the concept of immediate implant placement as an alternative to the classical delayed implant placement by the brain mark. So it is not a new concept. So here we are immediate loading the implant by various means, by by the use of bi-cortical implant, which engage the both of the corticals, or by the by modifying the techniques like all on four in four implants, tilted implants, pterygoid implants, jagomatic implants. So these are the techniques through which we can do the immediate loading. Now, full mouth cases or the segmental cases. So immediate implants we want, why? Because no one want to wait. Life is become very fast. No one want to wait for the teeth. Everyone wants the quick treatment, and it is, yes, it is beneficial for the patient. It is beneficial for the dentist also. So these are the advantages of the immediate loading implants. they have a shorter duration of edentulism, so shorter treatment time, no additional surgery needed. Even we can bypass the second stage surgery when we place the single piece implant. We need to just place the implant, took the impatient, and after 3 to 4 days, we can deliver the processes, whole process to the patient. So it has a very great impact, a very great psychological advantage for the patient. So just imagine patient comes in my clinic without it, and I'm sending it with the teeth, with the implant. So it is having very great advantage psychologically. But we can't do immediate loading implants in every situation. It is situation based. The 7 most important key I am going to share for the immediate loading. First is the insertion torque. The 45 NCM is required for that. ISQ value should be more than the 65. ISQ value means implant stability quotient, mean how much your implant is stable, and it is used in a, it should be used in a D1 D2 bone, or you can use the bicortical engagement. Implant should be more, length is more than the 10 mm. It should be active implant. Occlusion, you have to correct it very carefully, and obviously the absence of infection in spring implant is very important. If I am going to do a segmental rehabilitation with immediate loading, I have to increase the number of implant because I am going to load it immediately. Okay, so now there's a confusion. Which type of plant we should use? Conventional implant or bicortical implants? Are the immediate loading is possible every time? Conventional plants, most of the practitioners who are practicing conventional plants, they do the conventional plants. They don't like the basal implants, and some practitioners are using only basal implant. They are putting basal implant in all the cases where bone is present or not present. They are placing basal implants. In conventional plant, we should use either active implant or passive implant. Which system I should use? Where to use active implant, where to use passive implant, where to use conventional plant, basal implant. So it is a more confusing. So thing is that we can't use a single key for every law. Nowadays, many controversies are there. Some are saying that base implants where complete process comes out, so it is not working, it is not good. So it's not like that. Everything has a science. If you follow the science, you can deliver your patient to the best. The problem is that we are trying to open all the locks with a single key. If I'm using the conventional plan, I want to place conventional plan in all the cases. If I am using cortical basal implantologist, I'm I'm trying to put the basal plan in all the patient. So let's see where to use which implant, how to choose implant system according to the patient. We have to make a tailor-made treatment plan for the patient. So conventional plans, where to use? If we have a D1, D2 type of bone, what's a D1, D2, D3, D2, D4 type of bone? D1 bone is a dense bone where more cortical bone is present, uh, less soft bone is present, and D4 bone is soft bone. So obviously, when you are working in a D1, D2 type of bone, you will have a good torque. We have a good stability, implant stability. Then we can use for immediate implant. But when there's a D3, D4 type of bone, soft bone is there. In this type of bone, we should go with the delayed implant or conventional implant we should use in area with the high stress bearing area. Suppose if you are going to replace the lower six or upper six immediately, or we are going to load immediately. So in high stress bearing area, there is a chance of risk of failure of the implant. So in this high risk zone, we should use conventional delayed loading implants, because delayed implant placement remains a well-established and reliable protocol. This approach allows for the proper oscillation before subjecting the implant to the function loading. So hereby we reduce the risk of the early implant failure in the soft bone condition. So conventional implant, we can use delayed implant placement in the soft bone, in in high stress bearing area, we can use the delayed implant placement. And for the immediate loading implant system, we can use in the aesthetic zone, because no one want to live without teeth in a for a single day. Everyone wants a quick replacement. For aesthetic zone, we can loaded immediately, and in the D1 D2 type of bone where you go, where you get a good torque, good stability, or if you are engaging the bicorticals, both of the cortical, you can load the implant immediately. This allows the faster rehabilitation while ensuring the predictable outcome when proper case selection with surgical protocols followed. So these are the two concepts. One is the authentication. Conventional implant is based on the authentication, and second is the ossification in a corticobasal implant. Okay, so these are the two concepts. One is the authentication for delayed placement, on for ossifixation for the for immediate loading. So is there anything which is a system which has both also integration and through which we get a ossification? Yes, the Quickdent comes with a this implant system which is known as the TPR system. It is a we modified this implant system by making the smooth surface on the apical portion and corneal portion. We place this implant as a bicortical implant. This smooth apical portion engages the second cortical, and first cortical engaged by this smooth collar surface, and in between this there's a rust surface. So initially we are loading it immediately because we have a bicortical engagement, and over the period of time the bone formation occurs and it becomes osseointegrated. So in this implant system we get a ossification and osseointegration both. So nowadays I am shifting, I shifted my all the pets from the conventional or basal to the this hybrid implant system. And as I am a consultant and going to visit many clinics, so it has become more difficult to manage this all the thing. Conventional plants, I have to deal with the for the dealer with the for conventional plants, for the bicortical implants, and I have to manage the kit also. The kit for the conventional implants is different. The kit for the basal implant is a different. So I have to put all the system together. So search for the companies which has kits which through which you can place your conventional plant and bicortical plant. So nowadays I am using this Quickdent plant. It is a very beautifully designed kits through which you can place your conventional implant and bicontinent implant both. And I don't have to deal with the all the companies because this Quickdent implants has all the solution. If I want to place conventional implant, they have a conventional implant. If I want to place my implant in a atrophic jaw where bone is very less, I want to place base implant, they have a base implant, they have a compress implant. If I want to do immediate functional loading in a good bone with the sclerotin processes, then I will opt for the this hybrid implant, which is called the T3 implant for atrophic jaw. There is a zygomatic implants is also present. Everything is there. So at the end, the takeoff points are the first one decision lifetime thing. We place the implant with the belief that we can give a long-term solution, lifetime solution for the patient. So our decision is very important. So the right implant system ensures the long-term success, stability, and patient satisfaction. Second takeout point is precision over the popularity. Don't run after the popularity. Not all the implants work for the every case. Expert selection based on the bone and the biomechanism leads to the superior outcome. Whereas you have a soft bone and where you have soft bone, we can where you want 100% soft bone is there. You can use your conventional implant. When you has a atrophic jaw, you should use the basal implant because we want to give process to the patient so that they can eat this for their physical and mental well-being. So we should choose implants according to the patient's need and according to the situation of the bone. Okay. Third is engineering meets by the biology. Choosing the right implant means respecting the body's anatomy and ensuring the seamless integration and lasting function. So in this webinar, we saw the evolution plant, the different type of plants. We talk about the conventional plant, bicortical implants, immediate function loading. Immediate function loading, we use this hybrid TBR system, which is work on the which is work on the principle of tilted implant concept. So I hope you all enjoyed this session. So for any queries, you can contact me. And thank you so much, and wishing you a great journey of implantology. Thank you.
Thank you so much, Doctor. It was a great presentation, and you gave good insights about the topic. So, meanwhile, I request all the participants, if you have any doubts or queries regarding the presentation, drop in your questions in the Q&A box so that it can be answered. Doctor, for now, you can stop sharing your screen.
Okay, ma'am. Thank you so much.
No, you can just keep your video on and your presentation screen, you can stop sharing. All right, we have one question, Doctor. Can you please explain about tilted implants?
Tilted implants technique is used for the immediate function loading. Uh, Initially, we use to place implant parallel to the each other. This tilted implant is mainly for the full mouth rehabilitation. So in tilted implant, we engage our implant to the both of the corticals uh, and in the pterygoid zone. So these are called as a tilted implant concept, where we can do the immediate functional loading.
All right. I hope that answers your question. So the next question is, if compressed between augment bone, the minimum, what is the minimum space required? 1.5 remains the same.
Sorry, ma'am. Pardon, please.
There's a question that it's not framed
Uh,
properly, but I will just
yeah.
if compressed between augment bone, what is the minimum space required? 1.5 remains same. That's what
If
the question is.
ma'am, I think they want to ask about the extension socket. When we place implant in the extension socket, there's a gap between the bone and the implant surface, which is called as a jumping distance. So we should minimize it. Suppose if it is less than the 2 so then we don't need to put graft over there. And if the jumping distance is more than the 1.5 to 2 then we should place it. Fill it with the graft. So I
All
think
right.
they want to ask that question.
Yeah. All right. The next question is, can tilted implants be given only during immediate loading? Why and its needs?
Actually, if tilted implant is developed for the immediate function loading, okay, but you can load it after 3 to 4 months also. But why to need? The basic concept about the tilted implant is to engage the both of the cortical, and by splitting the implants, we can use it as the immediate function loading. So if we are using tilted implant, we should go for the immediate function loading. If you see the all and four concept, in all or four concept, we are also tilting the both of the implants. Okay, so it is not a new technique, that tilted implant technique. In all and four also, we are using the tilted implant, especially if we have very less bone in the maxilla or mandible. So we can't place the parallel implant throughout the arch length. So we are tilting implant to increase the span of the your bridge. So this technique is called as a tilted implant. Now we are using pterygoid implant. So uh, it is just like a all on four technique, and with this technique we place two more implant in the pterygoid region. So it become a all on six implant, and all are the tilted implants. So this tilted implant is should always use for the immediate function loading.
All right. I hope that answers your question. So the next question is, what all is required in a surgical kit for corticobasal implants, and what is the cost in Quickdent system?
Cortico-basal implants, they are generally 2 to 3 implants. They have only 2 or 3 discs only. And if we say about if you want to have a corticobasal implant. So basal implant kits has a two types of kit. One is small kits for the machine driven, and second is the hand driven kit. If you want to place the conventional implant, you have a separate kit. But here in the Quickdent system, they beautifully design this kit where some drills are for the conventional implants, 4 to 5 drills are there with the pilot drill, and for corticobasal implant we just need only one or two or three drills only. So they combine together in this Quickdent implant system.
All right. So they are also asking about the cost, doctor, of the system.
Cost varies with the company. The standard kit start from the 40,000, and if you want to go for the bigger one, it will cost around the 80,000. So it depend on the company to company.
All right. So the next question is, how many implants are required for full mouth rehabilitation?
Uh, for full mouth rehabilitation, minimum 4 implants are required. What we do in all-on-4 implant, but nowadays I am not using all-on-4 implants because it is well known that all-on-4 and none-on-3. If you place a 4 implant, you can have a process. If either one implant is going out, there's nothing to save. Okay, so always if we have a chance to increase the number of plant, it is always better. So I nowadays I always go with the 6 implant. 6 implant is a maxilla and 6 implant the mandible, and we can immediately load it. So minimum 4 implants are required. But if you want a long term, if you're looking for the long term solution, it is always better to go with the this hybrid system, that this TPAL system. With this system, you can place a 6 implant on the maxilla and 6 implant on the mandible. You can do the full arch rehabilitation in within a 5 days.
All right. The next question is, what are the locations for all on four implant supported rehabilitation?
Actually, all in for implant placement, the two distal implant is tilted such that the collar of the implant should be raised, should be come at the point of the first molar. Okay, if it is possible. So there, why we are tilting the implant? If we place the parallel implant, our in atrophic jaw, in parallel implant, our implant will be in a place of 3 or 9 region. But we want to give a whole processes for that to increase the arch of the span. We are tilting the implant so that the collar of the implant will reach to the molar area, and the apical portion engages to the nasal cortical. Okay, so all on four technique, we are using two tilted implant, one on the right side and one on the left side, and two implant at the lateral area.
All right. The next question is, can you please show the instruments in surgical kit for corticobasal implants?
Yes, ma'am. We can. For that, I have to share my screen.
Yes.
Okay. So in the last slide, I talked about the difficulty while doing consultation. Initially, I had to. Okay. So it is a conventional implant kit where you can see all the drills are there. Okay, and it is a now the lower one is a quick dent smart kit, where you can use where the first row of the drills are for the conventional implant, the second row of drills for the bicortical implants. There's a torque ratchet through which you can place the conventional implant. You can see the torque achieved, and this handle, this hand driven kit you can place your basal implant also, and there's an attachment for the basal implants too. So it is a very good kit. If you see this kit, it is a conventional kit where you can see the various drills, various attachments there, and cartridges. If we talk about the bicortical implant, generally we have two kits, one for the hand instrument, one for the motorized kit. So it is very difficult to take this conventional and cortical both together, but they have designed very beautifully this kit.
All right. Thank you, doctor, for showing us and explaining with the pictures to correlate better. So the next question is, in case of implant supported prosthesis, what is the attachment cap required between the prostheses?
Sorry, ma'am, can you please repeat the question?
Yeah, in case of implant supported
Uh,
prosthesis,
Okay.
the what is the attachment gap
Okay.
required between the prostheses?
If you look for full mouth rehabilitation, or if we talk about the process type process, it can be cemented processes or either can be skeleton processes. So in cemented processes, we are placing the abutments over the implant where we can load the our processes, and for the skeleton processes, we can use a multi-unit abutments, which is also known as a transmucosal abutment. From through this, actually in the tilted implant, in all phone implant, all the implants are not parallel. They are 30 to 45 degree tilted. To correct that angulation for the student processes, we can attach a multi-unit abutments through which we can give a student processes.
All right. So the next question is, which implant is best for single tooth replacement?
For single tooth replacement, in aesthetic zone, I always prefer the conventional implant. If possible, if bone is less there, then we, uh, uh, we can do the GBR and increase the width of the bone. But also, if it is an anterior teeth single implant, we can also uh, treat it with the basal implant too. Let me show one of slides again. Uh, so I always prefer conventional implant for the single tooth replacement. But in this slide, you can see that I have replaced this premolar because patient was immediate solution. Bone is not there, so I placed this bicortical implants and engage into the nasal cortical and give the prosthesis. So you can also use the bicortical implant, but in high stress bearing area, we should avoid the immediate loading implants.
All right. The next question is, can you suggest a PRF machine?
Yes, PRF machine we can use, as I told you about the surface modification. We have done lots of things that have the hepatite coating, these all the coating. So the PRF is the reach of the growth factor. If we want, we can use it over the implants, over the implant surface to make it more active. There are many papers are there which suggest that coating the implant with the PRF can little bit enhance the osseointegration.
All right. The next question is, which implant is used in atrophic jaw with soft bone?
Atrophic jaw with a soft bone. Basically, it is if it is a atrophic bone, it's mean it is all the cortical bone is there because there's a no bone volume. When there's no bone volume, all the bone is a cortical bone. And for the atrophic jaw, we should use the either the pterygoid implants, zygotic implants, or corticobasal implants. Okay,
All
and
right.
if you have a soft bone and sufficient volume of bone, you can go with the conventional implant with the also densification, so that we can modify the bone quality from D3 to the D2 by also densification. Okay.
All right. The next question is, what is the minimum width and the minimum height of implant for molar, premolar, and anteriors when there is bone loss?
When there's a bone loss, minimum implant width length, uh, there are some companies which made a 6 mm of implant. Okay, but if you want to replace the molar tooth, you can't use the 3 mm or 2 mm, 3 mm or 2 mm implant, because molar prosthesis is going to face lots of forces. So there you should use the wide implant like 4 to 4.2 mm or 6 mm or 8 mm. There's a one this is article is there which compare the standard 4.2 with implant with the bigger implant. So what is it? But at the end they found that there's a no major difference. But obviously, we should use the greater width and greater length of the implant. Length should be as much as possible, and width should be as much as wider. Width is more important than the length. When we increase the length of the implant 1 mm, it can increase the ossification by the 10%. But when we increase the width of the implant 1 mm, it increases the ossification by 33%. So width is very important. The smaller diameter available is 3 mm for conventional implants, and the smaller length available for with the company is the 6 mm. So if you want to replace the molar teeth, I generally prefer 4.2 to 5 mm width of plan with at least 10 mm of length. But some article suggests that you can replace it with the 6 mm length of implant with the 6 mm width of the implant.
All right. The next question is, can we place an immediate implant with immediate loading in a tooth with an abscess? And if yes, then what is the criteria for it?
Tooth with the abscess. Abscess means there's an active infection, and if there's an active infection, we should avoid implant placement immediately. It is a basic rule. Either you're using conventional implant or the bicortical implants. First, we have to treat the patient, reduce the infection, then only we should proceed for the implant placement.
All right. So the next question is, how do you access the bone quality and volume to determine if tilted implants are best option for me?
Nowadays, we have a CBCT, which will give you a good idea about the quality of the bone, type of the bone, angulation of the bone. You can plan your implant placement, how much till you want, where to plan your implants. So this CBCT is very helpful for that.
All right. The next question, they are asking about the cost, doctor. What is the price for one implant per tooth?
Cost for dentists or for the patients?
You can ask, you can tell both of them, doctor.
Uh, Cost of the implant ranges from for conventional implant 3,000 to 12,000, and for bicortical implant 3,000 to the 6,000. It depends on the company to company. So if you go with the Noble Biocare, these implants cost 10 to 11,000, 13,000. If you use the Korean implant system, basically implant system, if you want to categorize, it can categorize into two types. Majorly in India, we use the Israeli system, either Israeli system with the abutment joints, or we are using the Korean system. So obviously the Korean system is comes from the 6,000 to the 9,000. The Israeli system is comes from the 3,000 to 5,000.
All right. The next question is, can we use implants in children?
No, actually, it is recommended after the complete growth. When your growth is but completed, then only we can proceed with the implant placement. Then you can use the hand disc radiograph for assessing the bone growth.
All right. The next question is, can we connect the implant processes with natural tooth abutment?
No, never. Because see, our tooth is having a periodontal ligament, okay, and our implants are incarnates, they are fused with the bone. Okay, so one is the moving part and second is the stable part. If you join both together, it will harm your implant become fail. So we should never join tooth with the implant should be always joined with the implant only, not with the tooth.
All right. The next question is, can you please repeat what is basal implant?
Basal implant, basal implants, or you can call it a cortico-basal implant. Basal mean when you are using basal bone to engage your implant is called as a basal implant. Basal implants are generally smooth surface and single piece implants. In this implant, we are using the basal bone of the mandible. Okay, like in mandible, in intermandibular zone, we can is considered as a cortical bone. So here we can place the basal implant in the mylohyoid ridge, in the nasal septum, pterygoid. These are the second cortical. So whenever your implant is engaging to the second cortical, is called as a basal implant or bicortical implant. Actually, the bicortical term is more uh, good for the basal implant because in basal implant we are not using this basal bone. Okay, nowadays we are just engaging the both of the cortical in mylohyoid and this whole intermediate area is we consider is a cortical bone. So basal implant is the implant which is you engage the basal bone. Simple. And conventional implant are the endocyst implant which engages only the first cortical which is the elbow ridge and apical portion is surrounded by the cancellous bone.
Okay. The next question is, when to take impression for all on four?
When to take impression? Actually, all on four implant procedure or technique is derived for the immediate loading. Okay, so you can place the implant, you can place the multi abutment, you can take the impression, and you can modify your denture or you can give the processes to the patient.
Okay. The next question is, which is the best bone graft or the PRP material used?
Best bone graft material. So autogenous bone graft is gold standard bone graft. Actually, bone graft is a very big topic. We have a different types of bone is there, and we have to wisely choose in which area, which type of bone graft we should use. Where to use synthetic graft, where to use the allograft, where to use xenograft, where to choose it according to the situation where we need a uh, good natural bone. There we can use genograft with a allograft, and now a grafting technique is changed. Nowadays we use a composite graft in which one layer of genograft is there, one layer of allograft is there.
All right. The next question is, how much apical engagement is needed in the socket after extraction for immediate implant placement?
Let's immediate implant placement. The case assessment is the very important. If you are going to place immediate implant in the extraction socket, there are some conditions like you should have at least a 4 mm of bone apical to the fundus of the elbows means your extraction sockets to the nearest anatomical structure. You should have at least 4 mm so that for 2 mm apical engagement should be there. Mostly in the immediate implant placement in the extraction socket, most of the top, most of the stability, most of the engagement we get from the apical zone. So 2 mm minimum is required.
Okay. The next question is, how to convince a patient for implants instead of an FPD?
Actually, it is a wrong thing. We don't need to convince the patient for any treatment. As a dentist, we should give him all the options, removable option, crown and bridge option, and implant option, and let them choose. Yes, we have to tell it that this thing is disadvantage, this thing is a disadvantage, and this thing is having disadvantage. Don't try to convince or force the patient for the implant treatment. We are here, we are service provider, we as a dentist, we can we should tell the patient all the available option and let him choose. But how to convince the patient is an art. It starts with the questions. Like, if you ask the patient, actually when patient come to us, we directly jump into the processes. You want to bridge or you want to fix implant? No, this is not the right way. Actually, you should ask, sir, I am going to give you a processes. Okay, so which type of process you want, fixed or removable? Obviously they say fixed processes, so removal is out of the question. And when in the fixed, so you have to ask, sir, fixed, we have two options. Either we can have a support of the teeth to fix the teeth, okay, or we can give you a teeth which is naturally connecting to the bone like a natural tooth. So which type of tooth you want? You want a teeth which is more resemble to the natural tooth, or you want your two teeth to be supported? Then patient think, yes, I want a natural looking like teeth, which is not harming our both of the adjacent teeth. So in this way, you can convert your patient to the implant. Then comes the prices. What happens? We tell mostly patient the prices. Bridge is having 9 to 10,000, and implant is 25 to 10,000. One is not matter. Your approach. If patient convinced for the fixed treatment with natural tooth, he may convince or she may convince for the implant treatment. In this way,
All
you should.
right. So the next question is, in case of zygomatic implant cases, precursor taken, what is the difference between tilted cases and zygomatic cases?
Uh, Tilted implant is a concept in which we tilt the implant in the atrophic jawbone for the immediate function loading. Okay. Sometimes bone is very less, then we use a zygomatic implants and pterygoid implants. We also tilting that implant because we can't place zygomatic implant straight. Na? So zygomatic cases are the part of the tilted implant concept actually. There is only two concepts. You are putting all the implants parallelly or you are putting all the implants tilted. These are the two concepts. Zygomatic implant is a uh, is a implant only which is used in the atrophic jaw. Okay, so it is a same in tilted implant. If you have a good bone, you can place four implant in the intramaxilla, in the pterygoid region, to in the mylohyoid region, for in the in the intermittent region. You can load the processes. If you have very less bone, then you should place two zygomatic bone, two pterygoid, two zygomatic implant, two pterygoid implant, or quad zygoma for the full mouth rehabilitation.
All right. The next question is, if we use tilted implant, then how much do we have to use if we are doing all on six technique?
How much implant or how much tilt you should do?
Maybe how much tilt?
Okay, actually, tilt should we can, if we are using all on six technique, then you can go till the 30 degree. For the zygomatic implant, we need a 40 45 degree, sometimes 50 degree. But when you are using the all on six technique, where you are placing two pterygoid implants and four teeth implant, 30 to 35 degree you can use.
All right. The next question is, which implant is universal for tooth replacement?
Which implant is universal for the tooth replacement? I just told you that there's a nothing like a universal key. The problem is that everyone want to open all the locks with a single key. Cortico basal implantologist space basal implants all over. all over, whether you are having good bone or bad bone in single or segmental, everything. And conventional implantology is putting conventional implants in all over. Actually, we have to see the patient, we have to see the situation, what is the patient need, what is the bone condition, and accordingly, which is to. So nothing is, there's nothing like a best. Everything is best according to the situation. If you have a atrophic jaw, if you have a less bone, then you should go with the tilted implant concept or the corticobasal implants. That's all.
All right. The next question is, in all on six, how many tilted implants are used?
In all on six, when we say all on six and all on four, actually this number detect the number of implants. In all on six, six implants are used for full mouth, for full arch rehabilitation. For in all on four, we are using four implant for a single arch rehabilitation. Okay, so all on six and all on four name is given according in on the basis of the number of implant which we are using. So in all on six implant, we are using six implants. In all on four, we are using four implants
All
for
right.
single arch. Okay.
The next question is, the drilling depth. How much is it for corticobasal implant cases?
Corticobasal implant cases, what will be the drilling depth? Actually, for corticobasal implant placement, we need to perforate the second cortical. So that much length we can have. Mostly you see the guided surgery for conventional plan. Why? Because we have a CBCT, we uh, we have particular length, and in this length we have to drill. Suppose if you are going to place 10 mm implant in conventional plan, you should drill. You should do the osteotomy till to 11 to 11.5 mm so that you can place your 10 mm implant slightly submerged. Okay, but in corticobasal implantology, we have to perforate the second corticals. Okay, so that must. So at the time of surgery, at the time of the perforation of the second cortical, you will know that how much length I want. So while doing the corticobasal practice, I have to keep lots of implant length because my length is not standard. Okay, so at the time of surgery, I got to know that this much of length I have a perforation. Suppose I have a perforation on the 14 mm, then 15 mm of implant I have to place. So the 1 mm I can go inside the second cortical.
All right. The next question is, in case of tilted implant cases precaution taken by the implantologist, if the patient is suffering from any systemic diseases, then how to manage?
Uh, it is a different topic. In systemic disease, conventional or corticobasal implant. If patient is having osteopenia type of systemic disease, it is good to avoid implant placement. Simple.
All right. The next question is, which implants are best for the young patient with advanced periodontal disease? And if placed, does this periodontal disease affect implants in future, like implant mobility?
Yes, we should be very careful when we are dealing with the young patient and especially with the patient who is having chronic periodontitis, periodontal disease. So if patient is young, if we can create the bone, we can go with the conventional implant. But first we have to treat the patient or we have to extract all the teeth, wait for the few months, and then after we can go for the implant placement. If bone is sufficient, go with the all in six conventional or bicortical engagements, and you can give your fuller processes. But
All
always
right.
try to, if young patient, always try to give processes which is screw written processes, not a cement written process. Always.
Okay. The next question, I guess this has already been answered by doctor. How do you access the bone
Yeah.
quality and volume to determine if tilted implants are best option? Doctor has answered that's CBCT. Then the next question is, which factor determines the number of implants to be placed for full arch rehabilitation?
Bone volume, bone quantity, and bone quality is the determining factor when we are using the full arch rehabilitation. If you have a sufficient bone in maxilla and sufficient bone in mandible, you can go with the all-on 6 or even all-on 8. You can place 8 implant if you have a sufficient bone, and in mandible also. But in maxilla we have a soft bone, in mandible we have a dense bone. So when we are doing it with a conventional implant, so always place number of implant greater in maxilla than the mandible. Suppose if you are placing 8 implants in the maxilla, then you can go with the 6 implant in the mandible. Okay.
All right. Next question is the management of peri-implantitis.
Measurement of peri-implantitis. Peri-implantitis, actually, first we have to assess the cause of the periodontitis, peri-implantitis, stages of the peri-implantitis. Wait, stage of the peri-implantitis. If it is a, if actually the peri-implantitis will occur because of the lack of the follow-up. If you will follow the patient regularly, you can recognize it in its earlier state, like peri-implant mucositis. If you notice the peri-implant mucositis, you should treat the cause. Many of the time, because of the if our implanted is exposed, or if there's a not attached gingiva, soft tissue plays a very important role. Most of the clinician ignore these soft tissues. So attached gingiva is very important. If there's a lack of attached gingiva 100%, it will cause a recession and it will cause a peri-implantitis. Am I audible? Hello. Hello.
Yeah, I'm sorry, there was a technical issue. So there was a network issue. There were a few more questions, Doctor, but I guess.
Okay. It is already 3:20.
All right. We've exceeded the time limit. So,
Okay.
yeah, thank you, Doctor, for patiently answering all the questions. There were more than 30 questions, and it was a very insightful and informative presentation. Thank you so much to all the participants. And thank you again, Dr. Pandaw, for being our guest speaker today. So, we'll be ending the session.
Thank you so much, and thank you all of you for asking me a question. Thank you.
All right, Doctor. Bye bye.